बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। प्रोफेसर ज़ियाउल इस्लाम साहब और साकिब साहब के बाद कहने के बाद बात कहने की रहती तो नहीं है, लेकिन आई वुड लाइक टू ऐड कि व्हेनेवर पेशेंट कम्स टू यू, क्योंकि अभी तक आपने उसको डायग्नोज नहीं किया, आपके सस्पिशन है, तो सबसे पहले उसमें हिस्ट्री जो है दैट इज इम्पोर्टेंट, और उसमें रिस्क फैक्टर्स जो होते हैं वो लाजमी देखें। फॉर एग्जाम्पल रिस्क फैक्टर में ओल्ड एज है, मायोप्स है, डायबिटीज है, मायोपिक ग्लासेस लगाए होंगे। फिर डोंट विजुअल एक्टिविटी वगैरह करने के बाद जो है डोंट फॉरगेट अबाउट इंट्राओकुलर प्रेशर। और इंट्राओकुलर प्रेशर जो है दैट इज गोल्ड स्टैंडर्ड जो है, वो गोल्ड मैन है, वो नहीं है आपका ये जो एयर बफ एक्सेट्रा। गोल्ड मैन टोनोमेट्री, फिर जो है उसकी आप स्क्वायर देखें, उसके बाद जो ज्यादातर कोशिश करें अपना क्लिनिकल जो है उसको एग्जामिनेशन, आप डिस एग्जामिन करें, जो नर्व फाइबर लेयर एग्जामिन करें रेड फ्री लाइट के साथ विद मैग्निफिकेशन। और जो ज्यादातर रिकमेंडेशन आजकल तो है ना, जिस पेशेंट को आपने देखा फौरन उसको फील्ड के लिए और स्पेशली ओसीटी के लिए भिजवा देते हैं। ओसीटी की प्लेस जो है वो सिर्फ अर्ली जो प्री पेरीमेट्रिक ग्लाकोमा उसमें तो है, लेकिन बाद में जब ये डेवलप हो चुका है, जब स्टेज 2 या 3 पे चला गया है, फिर ओसीटी हर बार नहीं चाहिए, क्योंकि आपने ध्यान रखना है रिसोर्सेज की तरफ भी कि काम का वो भी जाया ना जाए, और इस तरह आगे फर्क चलते। थैंक यू।
थैंक यू। अच्छा, इस पर मैं कुछ ऐड करना चाहूँगा। ग्लाकोमा स्क्रीनिंग की बात मेनली है ना, तो ग्लाकोमा स्क्रीनिंग में दो कॉन्सेप्ट्स हैं, एक है यूनिवर्सल स्क्रीनिंग और एक है अपॉर्चुनिस्टिक स्क्रीनिंग। यूनिवर्सल स्क्रीनिंग ये है कि आप सबको स्क्रीन करें ग्लाकोमा के लिए, जिस तरह डायबिटिक रेटिनोपैथी वाले करते हैं, जिसको भी डायबिटीज़ होती है वो स्क्रीन कर लेते हैं। डायबिटिक रेटिनोपैथी की स्क्रीनिंग और ग्लाकोमा की स्क्रीनिंग में बहुत फ़र्क है। वो फंडस पिक्चर से सब कुछ कर लेंगे, हम सिर्फ पिक्चर से नहीं कर सकते, हमें प्रेशर भी चेक करने हैं, हमें फील्ड्स भी करनी है, हमें ओसीटी भी करनी है। तो ये यूनिवर्सल स्क्रीनिंग ग्लाकोमा में नामुमकिन है, तो उसके लिए उन्होंने अपॉर्चुनिस्टिक स्क्रीनिंग की बात की है। अपॉर्चुनिस्टिक स्क्रीनिंग ये है कि जो भी आपके पास आए किसी भी प्रॉब्लम के लिए, स्पेशली वो 33 ईयर्स से ऊपर हो, तो आप उसको एज अ ग्लाकोमा पॉइंट ऑफ व्यू जरूर स्क्रीन करें। एनी अदर क्वेश्चन फ्रॉम द ऑडियंस? Congenital glaucoma drug of choice.
Age less than 1 year.
It has been studied के जो आपके prostaglandin analogs जो हैं, they are safe in children. You can even use beta blockers provided there is no other problem. Beta blockers and topical carbon anhydrase, but you will have to avoid primary.
Avoid antagonists such as bromidine, and because they can cause depression and also increases conjunctival condition.
Sorry, I'm sorry, I'm interrupting. But keep in mind that congenital glaucoma primarily is surgical disease. Primarily it is surgical disease. Just for the time being, just to lower the pressure, you can use these drugs. Otherwise, it is primarily surgical disease. You will have to go towards surgery.
Yeah, but that is temporary to buy the time for the surgery.
मैं डॉक्टर जीशान से पेरिफेरी में कंसल्टेंट के तौर पर काम करता हूँ। मेरी पहली एक सजेशन तो ये है कि जो आपने क्वेश्चंस ऑडियंस से इनवाइट किए हैं ना, ये आखिर में होने चाहिए। मुमकिन है जो हमारे क्वेश्चंस माइंड में है वो आपने पहले क्वेश्चन तैयार किया हो, एक मेरी सजेशन ये है। लेकिन चूँकि आपने क्वेश्चन इनवाइट किए हैं, तो मेरा क्वेश्चन ये है कि मैनी ऑफ द टाइम वो कम अक्रॉस विद एंड स्टेज ग्लाकोमा, जहाँ पे CD 0.99 होती है दोनों साइड पे, लेकिन प्रेशर कंट्रोल होता है विद 4 मेडिकेशन। तो ऐसी सूरत में क्या करना चाहिए, क्योंकि वो लाइफ लॉन्ग मेडिसिन यूज नहीं कर सकता, कभी ना कभी वो ड्रग्स के अपने साइड इफेक्ट आते हैं, अपने एफिकेसी लूज हो जाती है। तो ऐसी सूरत में क्या उसमें करेजियस डिसीजन ले लेना चाहिए, इनफिल्ट्रेशन अपना जो सर्जरी है ट्रैप पे, ये क्या करना चाहिए?
Sir, you're absolutely right. This is the whole subject we are going to discuss right now. And it will answer most of your questions which you have just asked. So I think we should proceed.
First question. How you define advanced glaucoma? Is it that really straightforward? This is advanced glaucoma.
Now, when we say advanced glaucoma, it's a sort of end-stage glaucoma, and these sort of patients we see always in the developing countries. Because if you look at the developed countries, they've got a system, they've got GPs, and they've got ophthalmic technicians. So very, very rarely you will come across advanced case of glaucoma. It's always in the developing countries if you are coming across this sort of. Now, a patient comes to you with a very high intraocular pressure, around about 40, 50s. When you look at the optic disc, it's totally cupped, and if you check his field, it is within the 10 degree of fixation. So this sort of glaucoma you label as an advanced glaucoma. And these sort of cases are usually primary amyloid glaucoma, or sometimes exfoliative glaucoma, and very rarely angle closure glaucoma patients come to you. Now it is very heartening that sometimes we see young patients. I will tell you just a few days ago, a young patient of 30 came to me and he had a pressure of 45 in both eyes. One eye was no vision, only hand movements, and in the other eye, there were only 624. And then when you tell the patient that you have lost one eye and you have to you have to be treated so that you can reserve, you can save the remaining vision in your other eye, he goes into shock because he said that oh, nothing can be done to my eye. Can you put in intraocular lens and so on? And from physician perception, you are thinking how to help this patient because he has got only something remaining vision and you have to treat him. So that's why you start with the medical treatment, but if the medical treatment is not helping, then you have to switch over to surgical. But advanced glaucoma means end-stage glaucoma.
Sorry, it is 100% correct. But once we are discussing among the colleagues, it is better to say, it is all right to say end-stage glaucoma, but if you are discussing it in front of the patient, now the recommendation is call it as advanced glaucoma. Second, sir, you are absolutely right. The fixation is around 10 or less than 10, we are talking about the visual field. Plus, there is a scotoma, which is either splitting or encroaching onto the fixation points. That's the definition of advanced glaucoma.
There are different staging systems to describe the damage by glaucoma. And nowadays, glaucoma stage system 2, that is usually recommended. According to that, there are 5 stages. First, 0, no glaucoma. First, early glaucoma. Second, moderate glaucoma. Third is advanced stage glaucoma. Fourth is severe glaucoma, and fifth is end stage glaucoma. And as Professor Saab has said, and Colonel Saab has said that definition, that's very right. But any total or near total cupping of the disc associated with wheel field less than 10 degree and scotoma and either encroaching the fixation spot or splitting it. Now, the other question is that so simple? It's not that so simple. Because we are here basically talking about
glaucoma.
Now, if you see an advanced patient with advanced glaucoma, the progression is that you have to check the intraocular pressure, number one, whether it is controlled, he is getting control with the medical treatment or not. And secondly, you have to check his visual field, whether it is progressing or not. So these are the two main important factors in checking intraocular pressure, and second one is the visual field on which you can just think of the progression of glaucoma.
as our colleague just mentioned, advanced glaucoma by definition means that the damage is still going on. In spite of whatever the pressure you have brought that patient to, we'll be discussing about that regarding the target IOP. Now, regarding how to monitor the progression of advanced glaucoma, well, OCT is not the answer. Because OCT after a certain stage will have a floor effect, meaning that the Brooks membrane and the inner limiting membrane, once it reaches around 40 micron, it will just give you a red signal. So there, the important thing is go for visual field. And in advanced glaucoma, it is not 24-2, it is 10-2 which is recommended. And that you have to monitor and see whether that area is progressing or not. If it is more than 0.5 decibel increase with time, and you need to have at least 4 serial visual fields to say whether this progression is happening or not. You can't say that at the end, once the patient is losing sight. But if you are monitoring, patient has functional vision, then you can have serially monitoring of that visual field. That will determine that at what pressure should you keep that. We will be discussing that topic later on.
It was very elaborately discussed by Brigadier Sakib and Professor Yasa. The main thing is clinical examination of nerve fiber layer and optic disc, and of course Goldman's intraocular pressure. And visual fields, as Brigadier Sakib mentioned, that 10/2 is more important. I would like to further add that some patients, they are having difficulty in seeing the standard target. You can change that target from 3 to 5. Size of the target, you can change it. Further, the second part of this is what is your follow-up schedule for advanced glaucoma? This is something very important. You will have to treat such patients not like ordinary glaucoma.
It will not be controlled. So this education or counseling of the patient is very important. And let's discuss it ourselves. Sometimes you see this glaucoma, it's not that symptomatic. So people usually they just put drops one day, they forget about 2-3 days. Sometimes they are traveling, they don't have medicine. So there are so many factors which you have to consider in follow-up. Thank you.
Another point in the follow-up of advanced glaucoma is if patient cannot do visual field due to any reason, you can follow up that patient on OCT by doing a macular scan. Because in these patients, the macular thickness will go down, especially in the temporal region. So it is available in the spectral domain. We don't have the swept source, which we'll be discussing later on. That gives more information if we have that.
Thanks, sir.
Even we can do confrontation if we have source problem. Advanced glaucoma, even confrontation will give us idea of that.
No, Doctor, you can't. How can you? You have a 10 degrees visual field left. How can you know whether it is progressing or not? You can only have a general idea. You can just have a general idea that he or she is having advanced glaucoma. You can't check the progression of that disease. We are checking how to follow and see the progression, whether it is getting stabilized or not.
That is Goldman perimetry. That is done if you don't have that static perimetry, so automatic perimetry. Okay. Question number 3. What are the treatment options in advanced glaucoma and how do you prioritize?
Now, in advanced glaucoma, you would like to reduce the pressure drastically as far as you can. Normally, when you think of treating glaucoma, in early glaucoma and moderate glaucoma, you treat patients medically, or you just in some cases, in some centers, they treat them on laser, selective plasty, and so on. But really, in advanced cases, you have to think of the surgical option. Now, when you are thinking of the surgical option, you have to think of so many complications as well. And now these complications are this patient can get endophthalmitis, this patient can get phlebotomy, this patient can get cataract, and this patient can get so many other complications. And the most important complication which I come across is usually in some of the patients is what they say the losing of the central vision. And this is given the name of wipe-off syndrome. Like for example, patient has got 660 vision, and he has got a pressure of 30 or 40, and you operate on that patient, then that patient loses even that central vision, and that is called wipe-off syndrome. So you have to explain to the patient that I'm going to do surgery, but there is a possibility that you may get loss of the central vision. And I have seen in some of the patients in my case as well. Now the other thing is that when you are treating this patient, you treat them drastically by surgical treatment, right? Now, if you don't do surgery and the patient pressure is not controlled, again he is losing vision. So you have to explain to the patient that if you are operating, there is a chance that you may lose your vision. But if you're not to be operated, you will lose vision again. So that is the thing, and then you go for a surgical option.
As rightly said by Professor Darussalam sir, that it is entirely different to address the advanced glaucoma as compared to mild or moderate glaucoma. Here we don't have much time, and you will have to treat the patient aggressively. However, you will have to check certain things. According to NICE guidelines, answer is primary trabeculectomy.
So, and we don't know why, and in which patient it will happen. It is idiopathic. So, waiting and doing nothing is not recommended. If you have a patient, especially who come to you with initial very high pressure over 30, and he or she is having an advanced glaucoma, you don't have an option. You can buy time, meaning 2-3 weeks, lower the pressure so that you don't get complication during trabeculectomy. So you lower the pressure with the maximum medical treatment till the time that patient is ready to undergo trabeculectomy. Trabeculectomy is the answer.
When you are treating these patients with trabeculectomy, you have to take certain precautions. Before the operation, you have to convince the patient, as I said, for the wipe-off syndrome. And secondly, you have to reduce the pressure either by giving carbonic anhydrase inhibitor or giving mannitol, IV mannitol. Now, when you are giving anesthesia to these patients, you have to be very careful. Number one is always better to give local or subtenance injection. And if you are giving retrobulbary, you should be very cautious and just inject a very little amount. And it is very important that you don't pressure this orbital pressure, don't give so much orbital pressure to the patient. During the operation, it's always better if you do a peripheral paracentesis so that the pressure is low, and then you proceed accordingly, a slowly decompression during your operation. And it's always better if you can maintain the AC throughout.
We know about the quality of life of glaucoma patients. So do you consider the quality of life and health economics when treating your glaucoma patients?
Now, you see, when we are treating these patients with advanced glaucoma, we are thinking of number one, how to reduce his pressure and keep whatever his vision is there, just to preserve his vision, number one. And secondly, these patients always, they have got this routine problem. They cannot read properly, and they cannot do proper ambulation and so on. And even now I mentioned driving. Road driving is not a problem in our country because, but if you look at abroad, everybody is driving themselves. Even if they go to the petrol pump, they have to put the petrol on themselves. So these sort of things you have to think of how to help these patients. Apart from your medical or surgical treatment, you have to help them sort of rehabilitation or ambulation. Now, I was thinking that in our part of the country, this rehabilitation is not very popular, but I think we should always consider like we got speech therapists And we have got so many therapists, so we should have a rehabilitation visual therapist. So this is a sort of thing we should think of in the future in line. So there should be proper people who should rehabilitate these patients. Because doctors, they don't have so much time to.
Thank you very much. This question is very important. We will have to consider quality of light and economics as well.
Complicated glaucoma, especially post-retinal detachment surgery.
When you say a complicated glaucoma,
It goes towards
it
end
means that
stage.
you operated on a patient and his pressure is not controlled. So you can think of, if the vectomy is not working, then you can think of other options. The other options are number one, the drainage, aqueous drainage, this appliances and so on. And the third one is cyclodisablation, either with a diode laser or with a cryo and so on. If you think of the post-retinal disease, silicon, and silicon, you know, if you inject silicon, really it's a internal tamponade, but it can always cause problems. It can raise intraocular pressure, it can cause cataract, and it can cause endothelial damage as well. So these sort of patients, if you are treating them medically, well enough, if medically they are not really responding, we have to drain the fluid, drain the silicon oil, but in consultation with the vitreoretinal surgeon. Because if you drain.
How do you follow? What's your experience regarding intraocular pressure spikes with injections? नवीद कुरैशी साहब, उधर नवीद कुरैशी साहब।
नॉर्मली जो डीएबी के पेशेंट होते हैं उनमें इतना इशू नहीं होता, क्योंकि प्रेशर के साथ वेस्टर्न दवा आप लगा रहे होते हैं, 0.05 ml और that amount does not really until unless patient को पहले ग्लाकोमा है. The main problems are neovascular glaucoma, जो आप उसको ट्रीट कर रहे होते हैं, ऑलरेडी पेशेंट प्रेशर राइज होता है, आपने उसकी न्यूवेसल्स रिग्रेस करनी होती हैं, फिर आप यू आर नॉट एबल टू सी द. In that particular cases, normally what we do is that to do paracentesis and then we inject for the time being to get gain some time to go into the vitreous. Because due to corneal edema, raised pressure cannot directly jump into the vitrectomy. These kind of cases, these are really a matter of concern. Neovascular glaucoma वाले cases are tough होते हैं, क्योंकि already pressure ज़्यादा होते हैं उनको. उनमें इंट्राविट्रल इंजेक्शन देने में थोड़ा सा you should be very cautious. तो इस तरह के पेशेंट को paracentesis करके दे सकते हैं. और सेकंड जो आप बता रहे थे डीएलसी के जो आप बता रहे थे या साइक्लोक्रायोवैक्स एंड नॉट इन ऑल केसेस, अभी जो है सिलेक्टिव डीएलसी कर रहे हैं इन 1 क्वाड्रेंट, 4 क्वाड्रेंट में से 1 क्वाड्रेंट कर रहे हैं. अगर आपने 4 मैक्सिमम ट्रीटमेंट दे दी है, पेशेंट का प्रेशर कंट्रोल नहीं हो रहा, पेशेंट नॉट फिट फॉर द ट्रेबेक्टमी, स्पेशली इन दोज केसेस में आप स्टार्ट विद द 1 क्वाड्रेंट डायोड लेजर साइक्लोक्रायोवैक्स, एंड इफ इट इज नॉट गोइंग टू कंट्रोल यू कैन ऐड सेकंड क्वाड्रेंट. तो इस तरह से आप यू कैन सेव द
especially for advanced glaucoma with advanced diamond. हम छोटी छोटी चीजें जो है वो इग्नोर कर जाते हैं जिनकी बड़ी जो है ना वैल्यू है. फॉर एग्जाम्पल, आप लोगों ने ये जो गोनियोस्कोपी आप लोग रूटीन में नहीं करते, जो प्रोवोकेटिव टेस्ट है वो सिर्फ किताबों में रह गए, आजकल कोई कभी नहीं किया जाए. लेकिन जिस पेशेंट में एडवांस ग्लाकोमा है, अगर उसमें स्पाइक बार बार आती रहे जो कि अनचेक की है, दैट्स मोर टारगेट. फॉर एग्जाम्पल, मैं एक मिसाल देना चाहता हूं. कभी हमने नहीं सोचा कि रमजान है तो वो फास्टिंग कंडीशन है. आप वाटर ड्रिंकिंग टेस्ट कब करते हैं? फास्टिंग करते समय देते हैं पानी. तो ऐसे पेशेंट में यू विल हैव टू गाइड कि जब वो रोजा इफ्तार करें तो पानी इकट्ठा ज्यादा ना पिएगा, वरना 30 दिन स्पाइक आती रहेगी तो काफी कुछ डैमेज हो जाएगा. अपार्ट फ्रॉम दैट, कोई भी कंडीशन जिसमें स्ट्रेनिंग हो, इवन कॉन्स्टिपेशन है, पेशेंट इज स्ट्रेनिंग ऑन द डेफिकेशन, उससे भी स्पाइक आ रही है. कोई भी कंडीशन जिसमें आपका इंट्राथोरेसिक प्रेशर पड़ रहा है, उससे स्पाइक आ रही है. रात को पेशेंट आपका जब सोता है, स्पाइन सोता है, एक तो उसका ब्लड प्रेशर कम हुआ, दूसरा उसका इंट्राथोरेसिक प्रेशर बढ़ने की वजह से एपिसिक्लेरल प्रेशर बढ़ गया. ऐसे पेशेंट को यू विल हैव टू गाइड के वो अपराइट पोजीशन में सोए, ठीक है। इसी तरह वजन उठाना, बार बार वजन उठाना, अगर सपोज एक बार भी बंदा दिन में वजन उठाता है, वो स्ट्रेन की वजह से स्पाइक आई, जो डैमेज हुआ, जो अननोन नोटिस लग गया, एंड सो ऑन। इसमें जितने भी स्ट्रेनिंग वाले चीजें हैं वो पेशेंट को हमेशा गाइड करें कि अवॉइड करें। थैंक यू।
ये एक बात मैं बताना चाहता हूँ, जो हमने मेंशन लिखी है, टारगेट प्रेशर। हर एक कहते हैं कि व्हाट इज टारगेट प्रेशर एंड हाउ यू आर गोइंग टू मेंटेन। आई गॉट सिंपल फार्मूला फॉर टारगेट प्रेशर। इफ इट इज एन अर्ली ग्लाकोमा, then you keep early teens like 17, 18. If it is sort of moderate glaucoma, you always in the middle teens. Middle teens mean 15, 16. And if it is advanced glaucoma, you always keep them in the lower teens, that is 10 to 12. Thank you.
Sir, I'll add into this. Now I'll give you a complicated formula. Sir has given you a simple one. So that's a modified Jumble formula. Very simple. Initial pressure into 1 minus initial pressure over 100 minus the factor Z plus minus 2.
थोड़ी सी एक बात करना चाहूँगा
सर इसमें पूरा दिखना रहेगा समझाने के लिए।
One more comment. So there's a very good video. It's a Moorfield recommendation on how to do safe sewing. So you go on that videos by Professor Paul of Moorfield, and it will tell you how to do a good, safe trabeculectomy in the end stage patient.
रिगार्डिंग टारगेट प्रेशर, जिस साकिब ने बताया, ठीक है, वो बड़ा अच्छा फार्मूला है, सिंपल है, लेकिन मैं आपको उससे ज्यादा सिंपल चीज बताना चाह रहा हूँ, जो ज्यादा इजीली समझ भी आ जाती है और प्रैक्टिकली आप कर सकते हैं, और आई एम डूइंग इट फॉर द लास्ट मेनी इयर्स। अब वो मेरे साथी ने उस पर पेपर लिखा था, मैंने कहा बड़ा मुझे याद नहीं रहा। उसमें सिंपली ये है, टेक द परसेंटेज ऑफ द इनिशियल प्रेशर। फॉर एग्जाम्पल उतनी परसेंटेज, मतलब 30 प्रेशर है, 30% उसका ले लें, कितना बनेगा 9, ठीक है। अब देखें सीडी रेशियो कितनी है, सपोज सीडी रेशियो इज 0.9। अब 0.9 को 10 से मल्टीप्लाई करें तो क्या हो गया 9, दोनों को ऐड कर लें 18, 30 में से 18 को माइनस कर लें, दैट इज 12। It is very simple.
Thank you everyone.
ग्लाकोमा रोकने का फार्मूला
30 है, 30% कम कर